Good morning, myself Dr. Mrunal Akre, Assistant Professor, Department of Dravyagun, Global Institute of Ayurveda. In our pharmacological series now we are going to see our next topic, that is haemopoetics. Now what are haemopoetics? Generally haemopoetics, they are the substance which are required in the formation of blood and used in treatments of anemias. Generally, when the anemias are due to destruction of RBCs or when the RBC productions are lessened, blood loss is very acute or in chronic stage through piles, fissures or internal ulcers, or due to vomitings of blood vomiting, then impaired red cell formation due to deficiency of iron, vitamin B12, folic acid, or bone marrow depression that happens in aplastic anemia, then erythropoietin deficiency. In such conditions we use haemopoetics. Also in increased destruction of RBCs we use this haemopoietic agents. Now in haemopoietic agents, iron, first is iron. Now many if iron preparations, they are generally used for increasing blood level. In oral iron preparations, many drugs like ferrous sulfate, ferrous gluconate, ferrous fumarate, colloidal ferric hydroxide, carbonyl iron, they are used for increasing iron content, heme content of red cells, and which will anotherly it will carrying body oxygen carrying capacity will be increased. Now ferrous sulfate, it is an hydrated salt of iron, dried salt of iron. It is the cheapest one, and it often leaves a metallic taste in mouth. Generally when ferrous sulfate is given, then it will have that metallic taste in mouth and also in urine also. Next is ferrous gluconate. It is having 12% of iron, and ferrous fumarate, it has 33% of iron. It is less water soluble than ferrous sulfate and tasteless. Then colloidal ferric hydroxide, it is having 50% of iron. When there is severe deficiency of iron, at that time we used ferric hydroxide. Carbonyl iron, it is high purity metallic iron in very fine powder form. Particle size are less than 5 micrometer. Prepared by decomposition of iron pentacarbonyl, a highly toxic compound. Other form of iron present in oral formulations are ferrous succinate, that is 35% of iron, iron choline citrate, iron calcium complex, 5% of iron is there, ferric ammonium citrate, that is 20% iron is there, ferrous ammoniate, that is 10% iron, ferric glyceryl phosphate, ferric hydroxy polymaltose. Generally oral iron's complications or side effects are it creates epigastric pain, heartburn, nausea. It also creates vomiting due to that metallic taste, blotting in stomach, staining of teeth by black color, metallic taste, and colicky pain. Generally in children preparation we use ferrous gluconate, ferrous fumarate, and in severe condition we use ferric oxide. In parenteral iron, that is which is given IV or IM, iron therapy is indicated only when oral iron is not tolerated, bowel upset is too much, failure to absorb oral iron, malabsorption, inflammatory bowel diseases, chronic inflammation, rheumatoid arthritis, decreased the iron absorption. So in this condition we use parenteral iron. Non-compliance to oral iron in presence of severe deficiency with chronic bleeding. When there is chronic bleeding, along with erythropoietin, oral iron may not be absorbed. Parenteral iron therapy needs calculation of total iron requirement of patient. Several formula have been devised. A simple one is iron requirement in mg equal to 4.4 into body weight per kg. into HB digit, that is gram per dl. It will give us accurate measurement ki how much iron it is required in our body. Now maturation factors. Another maturation factors are there due to which iron is not present or anemia is caused. So first is deficiency of vitamin B12 and folic acid, which are B group of vitamins. Result in megaloblastic anemia, which is characterized by presence of large red cells precursors in bone marrow and their large and short-lived progeny in peripheral blood. Means in megaloblastic anemia what happens, in bone marrow we have large red cell precursors which produces RBCs which are short-lived and in peripheral blood. Means the time what is our RBC, they live only for 120 days in our blood, but this time period is shortened in megaloblastic anemia. This the destruction of RBC take place after say 50 days or 60 days or less than that also. So first we will see about vitamin B12. As you all know that vitamin B12 it is required in our body. Cyanocobalamin and hydroxycobalamin are complex cobalt containing compound present in diet that referred to as vitamin B12. Daily requirement is 1 to 3 microgram. In pregnancy and lactation it requires 3 to 5 microgram. Preparation dose generally cyanocobalamin 35 mg per 5 ml liquid, hydroxycobalamin 500 mg or 1000 mg injection are available. If we talk about India, in India injectable vitamin B12 are available mostly as combination and preparation along with other vitamins. B complex, Bicasul, they are its trade name. Next is folic acid. Folic acid, it is a yellow clay crystal which is insoluble in water. It is a sodium salt and freely water soluble. Chemically it is pteroyl glutamic acid, that is PGA, consisting of pteridine and para-aminobenzoic acid PABA plus glutamic acid. Its daily requirement is less than 0.1 milligram, but dietary allowances of 0.2 milligram per day is recommended. During pregnancy and lactation or any condition of high metabolic activity, 0.8 milligram per day is advised. Next is erythropoietin. Now this erythropoietin, it is essential for formation of RBCs. Erythropoietin it is a sialoglycoprotein hormone. It is produced in pretubular cells of the kidney that is essential for normal erythropoiesis. So this was our topic. Thank you.